So share screen. And as always, if you have any questions, go ahead and stop me, and I will answer any questions you have. Oh, darn it, that might have been the joints one. There it is. Okay, so this was this one was joints, I guess, of the hand. Is this the particular joints PowerPoint that you wanted to go over?
Yes, that's the one.
Is the one? Okay, great, awesome. So for joints, come on PowerPoint, you can do it. All right, so just remember a joint is the meeting of two bones. Articulation is the particular movement that they have in relationship to each other. Dislocation is when their normal arrangement is moved out of a line. Subluxation we see with the radial head, where it's normally in with the annular ligament. Reduction is when you put that joint back into alignment. So reduction is the opposite of dislocation. Ligament is that fibrous band that's connecting two bones together versus a tendon connects muscle to bone. And epiphyseal, the epiphyseal plate is where the bone is growing from. So you can see here in this picture, it's a dislocation of the glenohumeral joint. Here is your humerus, here's the glenoid fossa and your scapula. And obviously these two are supposed to articulate with each other, which they can't do because this bone has fallen out of the joint. So this is a dislocation here. So in this particular picture, you can see multiple different joints. So just recalling that joint meeting of two bones. So wherever you see two bones meet, technically that's a joint. So you have a sternoclavicular joint, you have your glenohumeral joint, and then you have your costosternal joints. So every time a rib meets the sternum, that's a joint. So any two bones. And when you have those two bones, you're going to have ligaments connecting them. So particularly here, you want to pay attention to the coracoclavicular ligament, which is composed of two different ligaments, your trapezoid and your conoid, and this is like one of the strongest ligaments of the shoulder. You also have your acromioclavicular ligament here. Thankfully for this one, it's telling you, like the ligaments tend to tell you what they're doing. So acromioclavicular, think attachment between the acromion and the clavicle. So the acromion from your scapula and then the clavicle. Let's see. Oh, so Hilton's law. This has come up in questions previously. So Hilton's law is just stating that the innervation of a joint is based on the muscles that are articulating the bones of that joint. So the nerves that innervate the muscles that are crossing that joint, those same nerves are going to innervate that joint. So it's one of those situations where the nerve is in the area, it's already articulating the muscle that's acting on the joint, so it can then give innervation to the joint capsule itself. So just want to give, like Dr. Austin gave this example here. Okay, so when it comes to your glenohumeral joint, there's a lot of different muscles that work on it, as well as bursa that are there to help ease the friction. So you can see here how you have your subdeltoid bursa that's fused with your subacromial bursa. And also there's a subscapular bursa that you can't see in this picture. And then again, here's your subacromial bursa.
Excuse me, Christian.
Sure.
This is Alana. Just to confirm, the subdeltoid bursa is a complete separate bursa from the subacromial. They're not one and the same, correct?
So that's the thing. I've actually seen it said where they're the same, and I've seen it separated like this. Like I've seen it said where obviously in this picture they're separated, but I've seen it in other pictures where they are the same. And I think I read it somewhere where the name is interchangeable. So that part is confusing.
Okay, so technically there's just like only one bursa to protect the shoulder joint, correct?
Correct, and it's all this area here.
Thank you so much.
Sure. Okay, so again, our glenohumeral joint. So important thing to note here, there is communication between the glenohumeral joint and your subscapular. So the synovial cavity of the joint and the subscapular bursa. So it is normal, because I know this comes up in questions, it is normal if you put fluid into the joint capsule for it to leak into the subscapular bursa. That is normal. What is not normal if it leaks into that subacromial subdeltoid bursa, this one. There is no normal communication between the subacromial subdeltoid bursa and the glenohumeral joint. If you get communication between them, that's pathological. Okay, and yes, so this is showing you subscapular bursa communicating with the glenohumeral joint cavity, and then let's see, synovial membrane shoulder joint. Yeah, it doesn't really, I think that's the biggest thing there. Okay.
Kristen?
Sure.
Hey, just a quick question. When did you say it's normal?
So it's normal if, like in questions, what they'll do is they'll say, their surgeon injected dye into the glenohumeral joint capsule, and then the dye extravasated is the fancy term. Basically, the dye leaked into the subscapular bursa. That's normal because there's actually communication between this joint cavity and the subscapular bursa. That is normal. What is not normal is if the dye leaks into the subacromial subdeltoid bursa. This fibrous capsule is only for that joint capsule. So that bursa on top of it should not communicate with this joint capsule.
Oh, okay. Thank you.
Sure, no problem. Selena Brown, go ahead.
For this slide, I remember talking about, she said the external part of the capsule. So that's the part that is what's normal to see. Anything internal is not normal, correct?
Correct.
Okay.
Yeah, for you to be able to see this, they had to cut away at the capsule, and actually they cut away the head of the humerus too to make room in this picture. Okay, and again, this is just showing you the same joint, but from a different angle. So there's two openings into the subtendinous bursa of the subscapular, which is the subscapular bursa. Okay, I'm gonna skip because there's more joints. Okay, so this is that whole talk about subluxation with the radial head popping out of the angular ligament. This is how you'll get it in questions, like a kid who gets jerked up by the arm. That's always the setup for subluxation. Speaking of, here's the head of your radius. That annular ligament is going to wrap around the head of the That annular ligament is going to wrap around the head of the radius. And that's normal. When you have subluxation, the head of the radius pops out of that annular ligament. When you have dislocation, the head pops out and then moves to the side. So it moves completely out of alignment with that ligament. So let's see, there we go. So here's a picture of that annular ligament. This is a posterior view of it. Important thing to know here, your olecranon, that's the bony process of your ulna, that's your elbow. So this is your elbow. And obviously, not obviously, but I've said it before, your humerus articulates with your ulna, and then your ulna articulates with your radius, both proximally and distally. And then it's your radius that articulates with your wrist bones. You can actually dislocate your elbow, which looks super painful. So just keep that in mind. That could be a possible question. You can see here how you have a subcutaneous olecranon bursa, a subtendinous olecranon bursa, because that triceps muscle is attached to your olecranon. And it's those three muscle bellies coming together to make that ligament that then attaches to it, to make that tendon that then attaches to it. So when you dislocate your elbow, you have this part. So basically, your ulna dislocates from your humerus here. And so this part will be popped forward, this part will be popped back. And there's definitely an x-ray that floats around that shows this. Okay. Other important things here. Yeah, now we're getting to the wrist and the hand. So you have a lot of different joints in the wrist and the hand. I'm trying to think what's important here. So knowing that your lunate is the most commonly dislocated carpal bone, obviously knowing that the scaphoid is the most commonly fractured, and if you fracture the hook of hamate, you could damage the ulnar nerve and the ulnar artery in the hand. What else?
Hey, Christian, real quick.
Sure.
She is only having 2 questions off of hand. And yesterday she mentioned about, I was just telling you so you wouldn't like go over too much, but she mentioned about like the DIP, the I said P, I mean DIJ, just those small things, and then maybe the interosseous, just so you won't have to like.
Sure. Yes, I appreciate that since we're on a time crunch. Okay. So when you're looking at the joints of the hand, so your DIP is the distal interphalangeal joint, which here we go. This is your DIP right here. So this is your distal phalanx, your middle phalanx, and your proximal. So your DIP is this joint here versus your PIP is this joint here. So it's the proximal interphalangeal joint, PIP. So when they say DIP, they mean here. When they say PIP, they mean here. And then you also have the joint, which is, I believe, your MIP, the metatarsal interphalangeal joint. So between your metatarsals and your proximal phalanx. Did she happen to bring up rheumatoid arthritis at all when it comes to the hand?
No.
Okay, then I won't go over it. All right, so we have 3 minutes left on joints. What other questions do you have about joints?
Kristen, I have a question about the question. Like, it's like 4 or 5 slides down where she gave a practice question.
Sure.
And it was basically asking like, you know, basically the child got a cookie and then she couldn't like supinate her arm and the answer was D. So what would make the answer E?
Distal radial ulnar joint. So in order for, do you even ever dislocate that? I don't know if you ever dislocate that. For you to do this, so this is talking about subluxation. That's where it's happening, is at the proximal radial ulnar joint, because remember that radius pops out of annular ligament and it's proximal.
Yeah.
For it to happen distally, like, I don't even know how you would do that. Because like this is it right here. Yeah, I don't know how you would do that.
Okay. I was just making sure, like, just trying to see it in another way, make sure, you know, it couldn't be answered a different way.
Yeah, because when they talk about like it can't, like the child can't supinate anymore, like they rest it in pronation. So you can see here, this is what it looks like in pronation. This is what it looks like in supination.
Yeah.
When you have subluxation, since that radial head has popped out of the annular ligament, it is just like, it's painful when you bring it back to subluxation, because that's actually how you put the joint back into alignment. Like for these kids, you like supinate and then flex the arm to get it back into alignment, and then they have to keep their arm in a sling for 2 weeks. So that's why it's all about this positioning here. This is going to be more comfortable for the kid because it's not popping that radial head back into the annular ligament.
Okay, thank you.
No problem. What other joint questions do we have? Okay, so we only had like 1 minute left, so that's fine. I'm going to pause.
Actually, I have a quick question.
Sure.
So with the angular ligament, that only takes place around the or near the joint with the radial ulnar joint. It has nothing to do with the humerus and the point where the humerus meets the radial or the radius, sorry, or the ulnar meets the humerus. It's only the radial ulnar joint, right? Correct.
So it's just here. So you can see how it's showing you how it's connected to the ulnar. So you can't see it too well, but yes, it has to do with the articulation there. Yeah. It doesn't have to do with the flexion or the extension of the humerus to the ulna. It's only about the radius articulating with the ulna.
Thank you.
Sure. Okay. And so, so with that, we're going to switch gears. Let me go ahead and exit out of the joints one. Okay, and so we said next we're going to do lymph drainage. All right. So, share screen. Okay, and it started on 15 minutes. Okay, so lymph drainage. Is there a way that I can talk about this without going to Google? Nope, we're gonna go to Google, unless I try and find the pictures that she had. Maybe I can find the pictures that she had. So not for y'all, but for a previous class, she talked about lymph drainage. Maybe this is the one. Where she actually talked about where lymph begins. Or are these mine? Oh no, these were my videos that I had. Okay, that's not helpful for you. So maybe I should talk through this. All right. So the way lymph works, blood goes through your vessels, and it goes through your vessels, eventually getting to your capillaries, so that lymph beginning, maybe that's what we want. It goes through your capillaries, and as it's going through your capillaries, it is giving off oxygen and nutrients and taking up CO2 and byproducts. Well, the thing is that there's actually some fluid that goes through, like out from the vessels in between your cells. And this is called the interstitial fluid. So even though most of your blood passes through your capillaries and then goes into your venules and your veins, there is some fluid that actually goes out of the vessels in between your cells. And that's your interstitial fluid. So that fluid has to be drained too. And when we drain that fluid, that's when we get lymph. So our lymph capillaries are this other set, like this other network of vessels that are there, that are draining that interstitial fluid between cells. And yeah, so that's where lymph starts. So you're starting at these lymph capillaries that are in between your cells. And then eventually, just like, you know, your little tiny capillaries turn into venules and then go off and become bigger veins, these lymph capillaries go into your lymph vessels, and then they're going to go to nodes and then drain. So when you see like the beginnings here, that's happening all over your body. It's just that these lymph nodes are areas where you have the fluid draining through so that your body can check for microbes and fight any disease. And I'm trying to think what else. Oh, and lymph is also a way that your body moves around fats in your body, but you don't need to know that yet. That's further on in your education. So yeah, so that's how lymph starts. It's the interstitial fluid in between your cells that's draining out so that you don't end up with like this huge amount of fluid overload, because otherwise the fluid would just stay in between your cells and you have, you know, swollen everywhere, like swollen tissues because of that interstitial fluid. So that's how lymph starts. Okay, so general overview. Oh no, this is actually talk about lymph. Go.
It's kind of like midway down when she starts on lymph.
Okay. Unless, am I in the wrong slide? Oh no, here we are. Okay.
No, you're in the right one. It's like mixed together.
Okay, that's fine. Okay, so lymphatics of the head and neck. When it comes to lymphatics of the head and neck, just know that a lot of these lymph nodes are named after where they are. So if you have a general idea, or if you're like generally good at knowing the different area names, you can figure out what lymph nodes there are. So like your submental, remembering mental is the point of our chin, our submandibular, meaning underneath the mandible, which is like the chin bone there. Our occipital nodes, referring to like this part of the skull, this particular bone is your occipital bone. Your retroauricular, meaning behind the ear, because auricular means ear. Also known as the mastoid nodes, because there actually is a part, like there's a bone back there, that's the mastoid process. Parotid, because they're over the parotid gland. Superficial cervical versus deep cervical. So cervical meaning neck, so it's the nodes that are superficial in the neck versus the nodes that are deep in the neck, and how you have upper and lower deep ones. And then the jugular lymphatic trunk, which I believe I learned is like the right lymphatic trunk. So there we go. So what's especially important with lymph nodes and lymph is understanding drainage pathways, because that way you can understand how you'll get movement of, say, cancer cells, how you'll end up with swollen lymph nodes in your neck. Well, if you have ingested something that is like making you sick, or if you breathe in something that's making you sick, like the pathway is going to be by your neck, and then trying to get back into like that venous blood system. So it would behoove you, because I think this has come up in the past, to understand or at least memorize some of these pathways, just to understand which area is going to drain into what. So if you have, you know, a nick on, like a cut on the front of your ear, like, or cut just in front of your ear, understanding that it's going to drain to the parotid nodes, versus a cut on the back of your ear is going to drain into the retroauricular or the mastoid nodes, versus like a cut on the back of your head would drain into the occipital nodes. Also knowing where you have the insertion of lymph drainage in your body, recalling that 1/4 of your body, so the right side, 1/4 of lymph drainage is on the right, versus 3/4 of lymph drainage is on the left. And it's the right lymphatic duct versus the thoracic duct. If it makes it easier for you, remember left thoracic, right lymphatic. So yeah, those two drainages. What else is important here? Oh, remembering that your jugulodigastric node is going to serve as a hub for a bunch of different pathways, as well as your jugulo-omohyoid node. And you can even see in the picture how much bigger they portray them, just to make the point that these are like major final pathways or major stops on the way for lymph to drain back into the venous blood system. Oh, so since some students are trying to go dental, I know questions come up about lymph drainage when it comes to the oral cavity, because that's going to relate to your education with teeth. So understanding that different parts of your tongue get drained to different lymph nodes, knowing the tip of the tongue goes to submental versus the sides of the tongue going to submandibular versus the posterior going into the jugulodigastric. I think she has a better color-coded picture for this later on. Yeah, this one. So seeing like the different areas that the tongue is draining towards. So submental, submandibular, oh, and your deep cervical nodes as well, for like the middle of the tongue, going to deep cervical versus the posterior going to jugulodigastric. Let's see what else is important here. Okay, since we have about 7 minutes left, I'm going to ask, are there any specific questions that you have about lymph drainage?
Yes, Kristen, maybe please go back over the one you just passed, the gray and black one with the
This one?
drainage.
Yes.
And it had stars. The next one, I guess, then. It looks just like this, but it has blue stars on it.
Those. Okay.
Oh, or maybe, oh, there it is. Okay, so I do remember learning that the jugulodigastric and the jugulo-omohyoid was like your main ending drainages. But like, okay, what's with this sorry, I can't read it. Oh,
Supraclavicular?
Yeah, wouldn't that be the last one or no?
In this pathway shown, yes. Let me see if we can see it on a different picture. But yeah, it's going jugulodigastric to jugulo-omohyoid to supraclavicular. Let me see.
But I feel like Dr. Austin makes a point that jugulo-omohyoid is like the end. So
well,
I feel like on a quiz.
Because you can take different pathways, like because it's this, you know, spider webby network, technically you can see here, so this is a netter plate. So here's the jugulodigastric and the jugulo-omohyoid. Here's the supraclavicular here. You can see how the jugulo-omohyoid is going, like is coming up on that drainage into the left lymphatic. Yeah, just lymphatic. Hold on, not lymphatic, jugular, thoracic duct. There we go. Sorry, early.
Yeah, it's okay.
Yes, you can see how the jugulo-omohyoid is going into the thoracic duct versus your supraclavicular nodes are also draining into there. So I don't know which one she's going to put more emphasis on, because it seems like, and you sort of have it in this picture too, how you're getting drainage from like the posterior part of the head versus the more like facial part of the head versus more of the medial neck.
Mhm.
So I don't know. I think this would have to be a Dr. Austin question as to which one, like which picture should take precedent over
Okay.
like a question like this one or the netter plate.
Okay, I get what you're saying.
It
And
is
then
so
one more
tricky.
question. So, oh, sorry, go ahead.
No, go ahead.
So the overall concept of the drainage, like my main question about just like the flow of the drainage, there's no particular flow because at the beginning of this 15-minute session, you mentioned how the lymphatic drainage is like intercalated into the capillaries, right? So they
Correct.
all web and come from different directions.
Correct.
Okay, just making sure I understood that.
Yeah, because this is happening like all over your body. When they
Mhm.
show, and I'll go back to that picture on Google. This is wherever you have capillaries. So wherever you have cells, you're going to have these capillaries. You're going to have this interstitial fluid in between the cells, and then you're going to have that interstitial fluid flowing out and entering the lymph capillaries. And once they enter the lymph capillaries, they're then technically lymph fluid.
And that's like the exchange, right? Like O2 and CO2. So what's going through the lymph is just like the leftover stuff, like proteins and stuff like that.
Yeah, so you
Okay.
can get proteins, you can get fats, you can get like more helpful is when you get microbes that then go to lymph nodes and activate your immune system, or
Mhm.
I'm trying to think what else. Yeah, those are like the biggest things that like end up in lymph. Oh, and
Okay.
fats, but once again, that's like later on in your education. That's more like biochem stuff.
Okay. Thank you. Thank you so much, Kristen. That really did help me.
No problem. Okay, we have about 3 minutes left. So is there any other specific questions about lymph nodes, lymph drainage, anything you want me to go over again? Okay, so then we will get rid of this one and then go to triangles of the neck. Okay, and then while I'm thinking about it, can I find my triangles? PowerPoint as well. Did I put it in here? Neck triangles, there we go. So I'll bounce in between the two if I need to clarify. Okay. So triangles of the neck, borders and content, and starting our 15 minutes. All right, so recall we have our anterior triangle and our posterior triangle, and the areas that are going to help you when remembering the borders. So you have your sternocleidomastoid, which is going to be the border between your anterior and posterior triangle. You also have your trapezius muscle, which is going to be posterior to the posterior triangle. You have your clavicle, and you have your mandible, as well as the imaginary midline of the neck that goes from the point of the chin all the way down to the jugular notch. So those are the big overall boundaries that you can see here. Okay. So shown in a netter plate, you can see how here the different triangles have been bordered off in color, although your posterior triangle is not separated. So your posterior triangle has 2 triangles, your anterior triangle has 4. And the border between the 2 triangles of your posterior triangle is this inferior belly of omohyoid, versus when it comes to your anterior triangle and those 4 borders, that's a little bit more complicated. So we'll just talk about those individually in a bit. All right, so your subclavian triangle, you can see here. So here's your clavicle, here's your omohyoid inferior belly, and here's your sternocleidomastoid. And then that is your subclavian triangle. So for the contents of your subclavian triangle, just remember, if it's the subclavian triangle, there's going to be stuff with subclavian in the name that are inside of it. So your subclavian artery, and your subclavian vein, as well as the trunks of your brachial plexus. So that one's nice and simple. Okay. And just showing you here the contents of the contents as they're going through. Cutting away at the clavicle so you can see underneath to see the contents a little bit better. So subclavian artery, subclavian vein, trunks of your brachial plexus. Do we not go into the other part of your posterior triangle? Okay. So when it comes to the contents of the other part of your posterior triangle, I guess the most important thing is just noting spinal accessory nerve as it's passing through. Yeah, you can see spinal accessory nerve, so cranial nerve number 11 passing through. So cranial nerve 11 innervates your sternocleidomastoid muscle as well as your trapezius muscle. That's its action. So it actually passes through this posterior triangle in between two layers of investing fascia. There we go. So note contents of this particular triangle: cranial nerve 11, sandwiched in between two layers of investing fascia, innervates sternocleidomastoid muscle, as well as your trapezius muscle. Okay, so now jumping forward to your anterior triangle, and this one's going to be more complicated because it's more specific. The borders of your anterior triangle, so this whole big triangle here, so you can see it's the anterior border of your sternocleidomastoid. It is the inferior border of your mandible, and then your imaginary midline of the neck, which is denoted by the mental symphysis, so the point of the chin, down to your jugular notch. So the apex of your sternum there, touching like your manubrium there. So this is your anterior triangle, which is then subdivided into 4 different triangles. Okay. So you have your submental triangle, literally submental below the chin. You have your submandibular triangle here, so submandibular below the mandible. You have your carotid triangle, which is going to have your carotid sheath inside of it. And then you have your muscular triangle, which has a bunch of muscles in it. So something to take note of, your hyoid bone is in the middle of things. So just notice that these are called triangles, but your hyoid bone tends to like stick into the triangles. It's a little bit odd, but just always find that funny. Okay. So your muscular triangle is called the muscular triangle because it has muscles. Particularly, it has your strap muscles. So memorizing your strap muscles is simply memorizing what 2 structures are they attached to. So for the most part, the exception being the superior belly of your omohyoid. But sternohyoid attached to the sternum and the hyoid bone. Sternothyroid attached to the sternum and the thyroid cartilage. Thyrohyoid attached to the thyroid cartilage and the hyoid bone. A lot of these, like the name tells you where they're attached, so it makes it easier. When it comes to your suprahyoid muscles, because before your strap muscles, that's the colloquial term for your infrahyoid, so below the hyoid bone. For above the hyoid bone muscles, your suprahyoid muscles, they're a little different. Those are more when it comes to the distinction between the 2 triangles within your anterior triangle that are above the hyoid bone. So your submental and your submandibular. Okay, and then we go on to the antecervicalis. Okay, here we go. So your submandibular triangle below your mandible, it's drawn into this picture here. So you can see the actual contents in this picture pretty well. So you can see how you have your submandibular gland, your submandibular lymph nodes, and you can see here how, I believe that's facial artery and vein. Yep, facial artery and vein pass through your submandibular triangle here. Okay. This is just the same thing, but with a different angle and a different cut. Okay, so moving on to your carotid triangle. Oh, so sorry, backtracking. The borders of your submandibular triangle, you can see how you have the anterior belly of digastric, the posterior belly of digastric, and the inferior border of your mandible for your submandibular. Versus submental, you can see here how you have the hyoid bone, the anterior belly of digastric, and that imaginary midline. And I'll just make note that depending on which textbook you use, depending on which professor you ask, sometimes they'll have it be one submental triangle, so the two of them combined, versus two separate submental triangles. I don't think it really matters either way. It's just knowing that the submental is about those infrahyoid muscles that you see there, and it's below the point of the chin. Okay, so for the carotid triangle, you can see the borders. You have your posterior belly of digastric, you have the anterior border of your sternocleidomastoid, then you have the superior border, superior belly of your omohyoid with that hyoid bone sticking out in the middle. And the carotid triangle is named so because the carotid sheath goes through it. So recalling back to when we were talking about fascia, your carotid sheath is made from contributions of the three main fascias. You have your investing fascia, your prevertebral, and your pretracheal fascia. Within your carotid sheath, you have your common carotid artery, you have your internal jugular vein, you have a branch of your vagus nerve, your ansa cervicalis is there, and the deep cervical lymph nodes, which you can see here in green. So an artery, a vein, a nerve, well, technically two nerves, and your deep cervical lymph nodes, which there should be, oh, go ahead.
Yeah, quick question. What did you say about the carotid sheath in regards to, well, in relation to our fascia layers?
Oh, this just that it's made by contributions from all three. I think Dr. Austin mentioned that in like earlier in the fascia part, how you have prevertebral, pretracheal, and then investing fascia all contributing to the carotid sheath.
Okay, thank you.
Sure, no problem. Okay. Trying to think what else is important here. Oh, so just again, a reminder about like the contents of your carotid sheath. When they're talking about the ansa cervicalis, you can see here is your ansa cervicalis. So the loop that is inside the carotid sheath on the carotid and internal, so see the common carotid artery and the internal carotid artery. And then you can see the external has come and then it's like sending off its branches. Okay, and then this is a lovely picture drawn to show the contents of your carotid triangle again. So you have your internal jugular vein, your common carotid artery, and your internal carotid artery. You can see it's not really showing the ansa cervicalis, but ansa cervicalis is in there, and branch of your vagus nerve. Okay. Talking about sympathetic, skipping. Oh yeah, so here we go. Our submental triangle, so knowing your borders. Here's your hyoid bone. Here's your right and left anterior bellies of digastric. Your mental symphysis to the point of the chin. And then the mylohyoid muscle forming the floor of the triangle here. The roof of all of your triangles is going to be your skin and subcutaneous tissue. So subcutaneous fat underneath. Okay, so I know I flew through those again. We have 3 more minutes. So any specific questions, anything you want me to go over again or clarify?
Christian, I have a quick question. The Ansa cervicalis, which I know that deals with like motor functions when we go into the face, so that's later on, but is that also referred to as the sympathetic trunk as well?
No, those are two different things.
That's
And
two
actually,
different things.
yeah, I'm glad you asked that question. So the Ansa cervicalis, it's giving motor innervation to muscles in the neck. So you have, nerve, so nerve to omohyoid, superior belly, nerve to omohyoid, inferior belly. So that's the Ansa cervicalis. It's all about motor. The sympathetic trunk, though, is about sympathetics. So remember, our sympathetic nervous system is part of the autonomic nervous system. The sympathetic nervous system is all about fight or flight. So that's like your body automatically like telling things what to do, versus when it comes to the Ansa cervicalis and muscles, like you actively tell those muscles what to do. So two separate innervations happening there, motor innervation versus sympathetic innervation. When it comes to the sympathetic trunk, that's stuff like, so for fight or flight, thinking about how, what's a good example for this? So for your eyes, how your pupils will dilate in order to allow in the most amount of light so you can see what's the best way to like run away from that thing that's threatening you. That's the sympathetic innervation. You have no control over that. Your pupil just does it. So that is like the nerves that cause that are running through these sympathetic trunks. So yeah, two separate things.
Okay, that makes a lot more sense. And so therefore, like the sympathetic trunks, excuse me, that's going to be a part of that carotid triangle, correct?
So you mean like within it?
Like, is it a part of the contents of the carotid triangle, or is it just near it but not a part of it?
That part. It's near it but not a part of it.
Okay.
So here it talks about how these are other contents in the neck and the cervical portion of the sympathetic trunk. So this is in the neck, but it's not like a part of that carotid sheath. So looking here, you have your superior cervical ganglion. I believe this is the middle, and this is the inferior cervical ganglion. A ganglion is like a collection of cell bodies for nerves. And what ends up happening, and this is like, and actually I'm going to pause because our 15 minutes are up in 10 seconds. Okay, cancel. What ends up happening is that your fibers for sympathetic innervation, they originate in your spinal cord. And then they come out from your spinal cord and like they synapse somewhere and then innervate their end organ. Well, like the particular sympathetic trunks here are for sympathetics in the head and neck. So you don't actually have those nerves synapsing until they get to these ganglia. So your inferior, middle, and superior ganglia. And then when those nerves synapse inside of that ganglia, they then branch out and follow along arteries to get to their end organs. And it's like in a completely random, well, not random, but a completely targeted fashion, such that they follow along the artery till they get to the end organ, and then they jump off of the artery to innervate the end organ. So this wrapping around that you see of the artery, that's the branching of those nerves coming out of the ganglia, trying to get to their end organ target. So that pupil dilation, that's an example of sympathetic innervation that's coming from these ganglia. There are other ones, but that's later. And hold on, is pupil dilation or constriction? I always get that one confused. I want to say it's dilation because all the rest of the body, it's constriction because it's rerouting blood flow to your muscles. So yeah, in the eye, it's dilation, but in the rest of your body, sympathetic innervation of blood vessels, like the muscles that control your blood vessels, is constriction because it's your body rerouting blood to your muscles so you can run away from the threat. Sympathetics is all about your survival. So I think about sympathetics as a bear has just popped up to my pathway. What is my body going to do to make sure that I can get away from the bear so I don't die?
Okay. Thank you so much. I appreciate it.
Not a problem. Okay, so it is 10:50. I'm now going to open it up to questions about anything because we have a little bit of time and I know you guys have your final on Monday. So any question, it doesn't have to be related to what we've talked about in the past 50 minutes. So can you do a quick review of transverse cervical artery and the cervical plexus real quick? Okay. What PowerPoints are those in for you? Because I don't remember what PowerPoints they're in. Sorry. Oh, they're in triangle. Oh, perfect. So I'll just pull up the triangle one. All right, let me see if I can find it. Do you, sorry to ask, but do you remember what, where in the slides they are? Just so I can jump to it so I can save time. $15, $16, okay. All right, so we'll share. All right. Oh, darn it. I thought I clicked on 15, 16. All right, well, we'll back up. Hold on, it's taking me too far. Slide 15. Oh, where are you? That one, please. There we go. Okay, transverse cervical artery and the cervical plexus. All right, so, well, here's transverse cervical artery. So transverse cervical artery is a branch off of your thyrocervical trunk, and your thyrocervical trunk is a branch off of your subclavian artery. So just as a review, your heart is going to pump oxygenated blood out to the tissues. It pumps out from the left ventricle through the aorta into the aortic arch. The first branch off of your aortic arch is your brachiocephalic trunk. Now recall that there's only one artery that's the brachiocephalic trunk, but you have two brachiocephalic veins. Don't get confused by that. I know it can be confusing because it's a repeating of terms, but you have one brachiocephalic trunk that is an artery, and then you have two brachiocephalic veins. Let's try and keep those two distinctions. Anyway, so your brachiocephalic trunk then splits into two. It bifurcates into your common carotid artery and then your subclavian artery. And then your subclavian artery has a bunch of branches too, but one of those branches is your thyrocervical trunk. From your thyrocervical trunk, one of its branches is your transverse cervical artery. So cervical meeting neck, transverse meeting across, so it's an artery that's literally crossing the neck. Does that answer your question about the transverse cervical artery? Okay, great. And now let's see, what was the last one? Okay, so we're gonna do cervical plexus and then call it. So for cervical plexus, do you mean like the ansa cervicalis or just looking at the whole thing?
I think on your PowerPoints, it's slide 10. Can you just go over that picture?
Oh, on
PowerPoint here, slide 10. I think I saw it.
there we go.
Go up.
I think this is it. Yes, okay. So cervical plexus, things to note. All right, so when it comes to the nerves coming out in the cervical region of your spinal cord, you're gonna have sensory branches, you're gonna have motor branches, you'll see some cranial nerves here, and you also have loops in between. When you have loops in between, just think of the fact that those fibers can then basically run like with each other. So first things first, let's talk about the cranial nerves that you see here. So there's two. We've already talked about spinal accessory, that's cranial nerve 11, and you can see here they're showing in this picture how cranial nerve 11 is going and innervating your trapezius muscle. They are not showing you your sternocleidomastoid muscle in here, but you got to know that cranial nerve 11 innervates your trapezius muscle and your sternocleidomastoid muscle. So that's this orange guy right here. This other orange guy is cranial nerve 12, hypoglossal nerve. And you'll note here, it's running along with this purple line right here. So this is fibers from cranial nerve, not cranial nerve, cervical nerve 1, so C1. So roots C1 are running along with the hypoglossal nerve here. But then what ends up happening is that C1 is going to give fibers to the ansa cervicalis, as well as is going to send innervation to your thyroid muscle, as well as your geniohyoid muscle. So you can see how geniohyoid and thyrohyoid, their nerves, like their nerve fibers, come from C1. And then C1 coming down to give you this superior portion of your ansa cervicalis, as opposed to C2 and C3 giving you the inferior portion of your ansa cervicalis. And then C3, C4, C5 coming together to form your phrenic nerve, which is going to go down and innervate your diaphragm so you can breathe. And then the mnemonic that we learned to remember, like phrenic nerve roots, was C3, C4, C5 keeps the diaphragm alive. And obviously this is super important because you need your diaphragm in order to breathe. You need to stay alive. So C3, C4, C5 keeps the diaphragm alive.
You said C2 and C3 do what now?
So C3, C4, and C5. C3, C4, and C5 keep the diaphragm alive, versus C2 and C3 are giving fibers to this inferior portion of your ansa cervicalis, whereas C1 gives fibers to the superior portion of your ansa cervicalis.
Gotcha. Thank you.
Yep. Oh, and then the sensory branches coming off of your cervical plexus. Once again, these nerves will tell you pretty much what they're doing, like where they're going to give you sensory innervation. So remember, this is sensory. So this is just you observing touch, pressure, heat is something wet. So it's like general sensation, not muscle innervation. So you can see how we have our greater this is greater auricular. No, this is lesser occipital. Greater auricular is in front of the ear. So lesser occipital nerve on this back side going towards like the under part of that occipital bone, versus greater auricular is going towards the front of the ear. You can see our supraclavicular nerves going to that top part of the clavicle. And you can see our transverse cervical, again, transverse cervical meaning going across the neck. I believe those are all like the big, those are the big points, I think, from this picture.
Question.
Sure.
This may be a silly question, but where is the vagus nerve in relation to this?
So it's not shown, but the vagus nerve, part of it is going through the carotid sheath. The other part is traveling on either side of the esophagus. So vagus means wanderer. Your vagus nerve ends up like all over your body. So you're not able to see it in this picture because it's not technically part of the cervical plexus. The vagus nerve is a cranial nerve. So technically it actually originates in the brainstem. But then like it goes and does a whole bunch of stuff in like your chest and your abdomen. Does that help?
Yes, thank you.
Sure, not a problem. All right, it's 10:58, so I'm going to stop sharing and stop the recording.